So the title of my talk is Smart Insulin Delivery in Type 2 Diabetes. And when I first got this topic, I wasn't entirely sure what it meant. So I've decided to talk about using novel technology in Type 2 diabetes to make the insulin delivery more smarter so that people get better outcomes. So these are my disclosures. Same sort of as yesterday. And I think you heard this morning from Prasad very elegantly the increase in the burden of type 2 diabetes. There's a huge amount of undiagnosed diabetes as well. And a publication in 2019 suspected or estimated that about 15% of people with type 2 diabetes would use insulin if they were to achieve a target of 7%. Now, this number probably significantly vary from region to region. I was chatting to Prasad this morning, so we probably have more beta cell dysfunction in South Asian regions than otherwise. It's also unclear how the availability of newer drugs like dual and triple agonist make the use of insulin in type 2, how it will affect the use of insulin. Hopefully, it will delay the need for insulin in type 2 diabetes, but nevertheless, I think insulin will have a role in management of type 2 for sure. And we also talked about this, and Nick mentioned earlier, type 2 diabetes is no longer a disease of the older obese people. We see more young people with type 2 now. In fact, in England now, there are more people with type 2 diabetes under the age of 40 than type 1 diabetes. That's an astonishing thing. And this is really a very aggressive disease. This is not just a smaller version of type 2. People with young type 2 has many other comorbidities, hypertension, obesity. They have much aggressive clinical course and tend to develop complications at much earlier age. So we really need to take care of this, younger age group really more seriously. Now, in terms of treatment target achievement, we know there has been huge progress in management of both type 1 and type 2, yet there are many people who don't reach targets. And on the left, you see the data from United States in the decade between in 2000 to 2000, up to 2018 or so. About 50% of people achieve an A1C below 7 and around 75% below 8. And on the right, you see data from United Kingdom, from the National Diabetes Audit. About 65% of people have an A1C below 7.5, but there is also a huge variation, and you can see the error bars are quite wide. These are different regions of UK, and you get a variability in control. Now, in terms of using drugs, and I just only want to focus on insulin here, and this data again from United States. You can see between 2000 and 2018, the insulin is the orange sort of line, and the use of insulin has gone up during this time from around 18% to about 26%. And out of that, about 2/3 of individuals are only using basal insulin. And there is still a relatively small use of SGLT2 and GLP-1 in that period, only about 7%. And these drugs are expensive in the United States as well, and the cost is a factor. So let's now look at some of the studies using technology in type 2 diabetes. And first of all, I'm going to show you a couple of studies in people on multiple daily injections in type 2 diabetes. The first study I'm going to show you is from the DIAMOND trial. This is the DIAMOND type 2 study. Those of you who were here yesterday, Nick mentioned the type 1 study for DIAMOND, and this is the type 2 dedicated study. They looked at people over the age of 25 with an HbA1c between 7.5 to 10. And they were using at least twice a day fingerstick testing. And what they found at the 6-week interval using real-time CGM, the Dexcom sensor, there was a significant improvement in HbA1c. Now, this also highlights the importance of doing randomized controlled trials. You can see the control group was also, there was a significant drop from 8.5 to 8, the orange line, but the sensor group dropped even more from 8.5 to 7.7, and a between group difference of 0.3%. And on the cumulative chart, you can see that the sensor group had, any given A1C, there were more people below the line in the using sensor group, and the time in range also improved using sensors. Now that is real-time CGM. What about Flash, which is a much more accessible option? So this is the Libre Generation 1 used in this study, one of the earlier studies conducted in Europe. This was also randomized control, 2-to-1 randomization, people with A1C greater than 7.5 and below 12%. And they were also testing self-monitoring blood glucose at least twice daily or more than 10 tests per week, and randomized to Libre or the continuation of self-monitoring blood glucose. Now, unlike the previous study, in this study, overall, the study was negative. There was improvement in both arms, but the difference between the two groups was not statistically significant for the HbA1c. However, there was a pre-specified endpoint of people under the age of 65, which is the bottom right panel here. And in that group under the age of 65, there was statistically significant improvement in HbA1c. In addition, the hypoglycemia, you can see on the table, time below 70, 55, and 45, they were significantly reduced on the arm using the Freestyle Libre. So that is MDI. So what about people on type 2 diabetes simply using basal insulin? As I said, about 2/3 of people are only on a basal insulin in the Western situations. So in here, there was a recent, relatively recent, well-done study called the MOBILE study. And this study also 2-to-1 randomization, those over the age of 30, using a Dexcom 6 system. This is now a factory-calibrated sensor with an A1C between 7.8 to 11.5. The study was done in the United States. Although the study was conducted in endocrine practices, the patients were under the primary care physicians, and the study team simply passed on the advice to the primary care, so the actual treatment changes were done in primary care. And once again, you can see there was a significant improvement in both groups, but on the sensor group, there was bigger drop in A1C with a between group difference of 0.4%. If you look at time in range, this was significantly better, 59% versus 43% in those using sensors. And there was reduction in hyperglycemia. The time above 250 came down to nearly halved on the sensor group. Hypoglycemia is small in this group. They were largely running high, but there was still statistically significant reduction in this group. But what about the insulin use in this study? So in a nutshell, really, there was no increase in the use of insulin, either total daily dose or the basal insulin in the group that used the sensors. So in other words, how did they improve? It's not by doing more insulin. So it is more likely that this improvement was really due to lifestyle modification that was made possible by availability of data. And I can tell you a number of anecdotal stories around this as well. But let's look at one other thing. So I know this talk is around insulin, but I just want to show you one study in type 2 diabetes which are not using insulin. So this is a recent publication called the Immediate Study from Canada, and this is also a multi-center trial, HbA1c more than 7.5 or more, and they were randomized to Freestyle Libre once again, and the control group. I hope you can see this table, and if you look at the time in range on the Libre arm, the time in range went up to 76% compared to 65% in the control group. In other words, significantly more time spent in the target range. You can also look at that second line, the time in tight range. This is becoming a newer concept now. So this is between 70 and 140 milligram per deciliter, or 3.9 to 7.8. And once again, there was significant improvement in that time spent in that very tight range of glucose using sensors. So these individuals were not taking insulin. There were no change to their other medications. So this is again thought to be largely due to changes in their behavior in the study. This is a study from United States. So this is a retrospective observational study, comparison to previous studies I showed you. This study looked at two groups of people, one on insulin and one on not on insulin. And you can see in both groups there was significant improvement in HbA1c of 1.1 drop in insulin group and 1.6% drop in non-insulin group after starting Freestyle Libre device. So once again, some evidence that the sensors might be useful. So this is a data from United States. So this is Dexcom G6 data, and this is a real-world study in large number of people, around 7,000 patients who are using Dexcom sensor in type 2 diabetes. On the top panel, you see the type 1 data, and the bottom panel, you see, in the second line, you see type 2. But importantly, these are all non-insulin treating type 2 patients. And if you look at time in range, around 70% in the type 2 group. But what I want you to really see is the use of various features on the second part of the table. You know, the sensors have features like urgent, low soon, low threshold, high threshold, and you know, things like that. If you look at the use of these features by people with type 2 diabetes, even not on insulin, is really comparable to people using type 1 diabetes. So in other words, these people with type 2 diabetes were still using these sensors really very interactively like people with type 1 diabetes. So what is the situation in UK with regards to type 2 diabetes and sensor use? So we can now offer continuous glucose monitors to selected patients with type 2 diabetes. As you can see here, if they have recurrent hypoglycemia or severe hypoglycemia, impaired awareness, they can be offered real-time. They can be offered sensors, mainly Libre, but we also have real-time CGM at a similar cost in UK now, so these can be offered to people with type 2 diabetes. So that's the bit about the sensors. So let's look at a study of using insulin pumps in type 2 diabetes. So I choose this particular study because for a couple of reasons. One, they used people already using multiple daily injection therapy. And secondly, they had an optimization period. So for 2 months before entering into the randomized study, they really optimized these patients. They gave the best possible chance for them to improve using multiple daily injections. And they were only randomized if they still have high glucose, between A1C of 8 to 12%. So after optimal treatment, they still had high HbA1c, and then they were assigned to an insulin pump versus multiple daily injection therapy. And these are the baseline characteristics: the mean age around 55, duration of diabetes about 15 years, HbA1c 9% at baseline, and their total daily dose of insulin around 110, 112 units per day. So they were using relatively high amount of insulin, and their BMI around 33. So if you look at the results from the optimized study here, and you can see with the use of the pump therapy, there was significant improvement in HbA1c and the between group difference of 0.7% at the end of 6 months period. And this was achieved, and if you look at the total daily insulin dose, once again, interestingly, they they were given less insulin than the people on injections. The red line, you can see the pump group needed less insulin, and with less insulin, better outcomes using the insulin pump therapy. So finally, we move on to the most advanced insulin delivery method, the automated insulin delivery or the closed loop system. This is a more recent trial published from the Cambridge group. Here they use fully closed loop, so they didn't need to give any bolus insulin. And you can see the baseline characteristics, again, BMI around 35, duration of insulin therapy about 8.5, around 8 years, and about 0.7 units per kilogram body weight. This was an 8-week trial, and if you look at the time in range, in the closed loop group, it was 66% compared to the control group of 32. So this was an algorithm specifically designed for type 2 diabetes. There was no need for bolusing, unlike type 1. This is fully closed loop, so the patient connects to this system and the system automatically gives insulin day and night. And the HbA1c 7.3 versus 8.7, so quite a dramatic effect. And if you look at the glucose profiles, in pink on the top panel you see the closed loop, and on gray you see the control. And you can see what a huge difference that the closed loop can make for the glucose control in this particular group. So, and you can see on the bottom panel the insulin delivery in the closed loop. So, to summarize, really, the incidence of type 2 diabetes is increasing worldwide, and the trends in younger people are particularly worrying, and about 30 to 50% do not reach glycemic goals. And evidence so far suggests that novel technology may be beneficial in both intensively treated type 2 as well as basal and non-insulin treated patients. And some of the benefits might be due to lifestyle modifications made possible by the sensors, and further work is needed to establish the full potential of these these devices. As you know, treatment of type 2 diabetes is changing continuously. We have newer and newer agents, and whether what the role of the sensors in these people needs to be still established. So with that, I will stop, and we'll be happy to